Cardiorenal syndrome is defined as a disorder defined as disorders of heart and kidneys, whereby acute or chronic dysfunction in one organ may induce acute or chronic dysfunction of the other. It is a pathophysiological condition in which combined cardiac and renal dysfunction amplifies the progression of failure of individual organ, so that the cardiovascular morbidity and mortality in this patient group is at least an order of magnitude higher than in the general population. Coming to the epidemiology, impairment in kidney function is common in patients with heart failure and is associated with worse clinical outcomes than in persons without impaired kidney function. The ADHERE trial included more than 1 lakh patients admitted with acute decompensated heart failure. In these 1 lakh patients, 91% had some degree of renal dysfunction, of which 64% have CKD stage 3 or higher, 27.4% had mild renal dysfunction, 43.5% had moderate renal dysfunction, 13.1% have severe renal dysfunction, and 7% had a GFR less than 15 ml requiring and were on chronic dialysis. Coming to the types of cardiorenal syndrome, 5 types were proposed by Acute Dialysis Quality Initiative in 2008 based on the pathophysiology. Type 1 is acute cardiorenal. Both type 1 and type 3 are in acute setting, and type 2 and type 4 are in chronic setting. Type 1 is acute cardiorenal, where heart failure leads to acute kidney dysfunction. Type 2 is chronic cardiorenal, where chronic heart failure is leading to chronic kidney disease. And type 3 is acute nephrocardiac, where acute kidney dysfunction leads to acute heart failure. Type 4 is chronic nephrocardiac, where CKD leads to heart failure. Type 5 is secondary to systemic diseases, where there is simultaneous dysfunction of both heart and kidneys. Before going to the predisposing factors and pathophysiology of different types of cardiorenal function, we should know how to evaluate the change in kidney function. AKI, it refers to abrupt reduction of kidney function resulting in retention of urea and other nitrogenous toxins, dysregulation of electrolytes, and retention of extracellular volume. As per KDIGO, AKI is classified into 3 stages, 1, 2, 3, based on the serum creatinine and urine output criteria. Stage 1 is increase in serum creatinine 1.5 to 1.9 times the baseline, or more than 0.3 milligrams per deciliter increase, and urine output of less than 0.5 ml per kg per hour for 6 to 12 hours. Stage 2 is 2 to 2.9 times the baseline creatinine, or less than 0.5 ml per kg per hour urine output for more than equal to 12 hours. Stage 3 is 3 times the baseline serum creatinine, or increase in serum creatinine to more than 4 milligrams per deciliter, or initiation of RRT, or in patients less than 18 years, decrease in GFR to less than 35 ml per minute. And urine output of less than 0.3 ml per kg per hour for more than 24 hours, or anuria for more than or equal to 12 hours. Then what is worsening of renal function? It is defined based on GFR, cystatin C biomarker, and creatinine. Based on GFR, more than 25% decrease in the GFR is considered as worsening of renal function, or more than 5 ml per minute per year decrease of GFR is also considered as worsening of renal function. Then based on cystatin C, if more than 0.3 mg per deciliter of increase in cystatin C is present, it is considered as worsening of renal function. Based on creatinine, it is more than 0.3 mg per deciliter increase, or more than 25% increase in creatinine, or more than 0.5 mg per deciliter increase, or 1.5 times the baseline increase in creatinine, or more than 25% increase with creatinine above 2 milligrams per deciliter. All these 3 are considered as worsening of renal function. So what are the predisposing risk factors for cardiorenal syndrome? One is obesity. Obesity, it increases cardiorenal metabolic syndrome. It causes cardiorenal metabolic syndrome, which increases the chance of CRS up to 7 times. And other risk factors are hypertension, diabetes, atherosclerotic disease, anemia, and nutritional deficiency. We'll see how anemia turns a vicious cycle of cardiorenal syndrome. So anemia, it causes tissue hypoxia with increase in the nitric oxide, which leads to peripheral vasodilatation and decrease in the blood pressure. This decrease in blood pressure decreases the renal blood flow and GFR, which leads to activation of renin-angiotensin system and increase in the sympathetic activity as well. This causes fluid retention, increase in the plasma volume, thereby increasing the left ventricular hypertrophy and dilatation, and increase in the BNP levels. Eventually, there will be inflammation, cell death, leading further causing the CHF, and this congestive heart failure further exacerbates the anemia. Thereby, this propagates the condition further. Coming to pathophysiology of cardiorenal syndrome, there are various mechanisms involved in cardiorenal syndrome. One is RAS activation, renin-angiotensin system, aldosterone system activation, sympathetic nervous system activation, production of reactive oxygen species, inflammation, endothelin effects, and arginine vasopressin effects. So what is cardiorenal axis? So we have hemodynamics controlling the cardiorenal syndrome, and there are certain non-hemodynamic parameters which cause the cardiorenal syndrome. The non-hemodynamic parameters are activation of sympathetic nervous system, increased activation of renin-angiotensin aldosterone system, inflammatory markers, and imbalance between the nitric oxide and reactive oxygen species. Whenever there is these four form the four are called the cardiorenal connectors. Whenever there is dysfunction in one organ, there will be changes in this four cardiorenal connectors, leading to dysfunction of other organ. So various mechanisms in cardiorenal syndrome. So, whenever there is a volume overload state, there will be increase in the central venous pressure and intra-abdominal pressures. This leads to activation of renin-angiotensin aldosterone system and sympathetic nervous system, causing water and sodium retention. Effects of this mechanism on kidney are renal venous congestion and decreased GFR. And in heart, it leads to remodeling of the heart. With heart failure, there can be decrease in the cardiac output and cardiac index, which leads to decreased perfusion pressure, decreased vascular resistance. This causes reduced renal perfusion and renal ischemia, and it also leads to cardiac ischemia from reduced perfusion. Third mechanism is neurohumoral dysregulation, where there is increased activity of renin-angiotensin aldosterone system and sympathetic nervous system, release of arginine vasopressin and adenosine. So this happens due to impaired baroreceptor reflexes and increased chloride delivery to macula densa. This promotes the release of renin, which in turn increases the angiotensin 2 secretion. This angiotensin 2 is a potent vasoconstrictor, and it has several deleterious effects over both heart and kidneys. So this angiotensin 2, it leads to endothelial dysfunction, inflammation, and fibrosis. This angiotensin 2 promotes the secretion of aldosterone, which causes water and sodium reabsorption. And angiotensin 2 also increases the expression of endothelin 1. This endothelin 1 is also a potent vasoconstrictor. It also causes oxidative stress. Then then there is release of adenosine, which is due to increased delivery of sodium to distal tubule. All of this causes arteriolar vasoconstriction, decreased GFR, increased water and sodium reabsorption, inflammation with fibrotic effect in both kidneys and heart. Then there is oxidative stress. This occurs due to imbalance between the oxidants and antioxidants. Whenever there is whenever the oxidants outnumber the antioxidants, there will be oxidative stress, increase in the reactive oxygen species production, and the angiotensin 2, it increases the NADPH oxidase activity, thereby further increasing the free radical formation. And in case of renal failure, there will be accumulation of uremic toxin mediated cytokine release. All of this lead to oxidative stress and causes hypertrophy, accelerated atherosclerosis, endothelial dysfunction, inflammation, and fibrosis in both the heart and kidneys. Next, there are inflammatory mediators like TNF alpha, tweak, and IL-1 family, IL-6, and PCR. All of this causes accelerated atherosclerosis, inflammation, and fibrosis. It causes left ventricular dysfunction and hypertrophy, myocardial cell apoptosis in heart, and glomerular damage by mesangial cell apoptosis in kidneys. Then there are certain renal failure related disturbances. Whenever the patient is having a kidney failure, there will be increase in the protein-bound uremic toxins, increase in the chronic inflammatory cytokines, oxidative stress, elevated FGF23 levels, which leads to calcium phosphate abnormalities. There will be erythropoietin resistance causing anemia, and kidney failure also leads to electrolyte disturbances, acidemia, and coagulation imbalances. All of this causes endothelial dysfunction, atherosclerosis, and vascular calcifications in the heart, and left ventricular dysfunction and hypertrophy, ischemia, arrhythmias. Electrolyte disturbances can cause arrhythmias. In kidneys, they cause atherosclerosis, inflammation, and fibrosis. Apart from this, there are certain iatrogenic factors like drugs like ACE inhibitors, ARBs, ARNI, diuretic, and certain contrast agents which are nephrotoxic. So coming to the pathophysiology of specific types, type 1 CRS. CRS1 is defined by rapid reduction of cardiac function, which leads to AKI. And prevalence of CRS1 was 25.4%, categorizing renal outcome by AKI. More than 30% of ADHF hospital admissions had a history of renal insufficiency. ADHF has 4 types: dry and warm, wet and cold, wet and warm, and dry and cold. But the main mechanism is thought to be increase in the central venous pressure due to volume overload, which causes AKI, renal venous congestion, and AKI. So, the predisposing conditions which cause acute heart failure are ischemia, cardiomyopathy, and arrhythmias. This acute heart failure leads to decrease in the cardiac output, resulting in renal hypoperfusion and causes AKI. Also, there is, because of acute heart failure, there is volume overload causing increase in the intra-abdominal pressure, increase in CVP, venous congestion, which decreases the renal pressure gradient, leading to AKI. Apart from this, there is activation of renin-angiotensin system, aldosterone system, and activation of sympathetic nervous system, both of which cause increased vasoconstriction and increase in the sodium and water retention, increase in sodium and water retention, leading to AKI. And there is increase in the humoral signaling, which leads to increase in oxidative stress and cytokine secretion, which can also lead to AKI. Apart from all of this, there are iatrogenic causes, which we have discussed earlier, like diuretics, ACE inhibitors, and contrast agents. They are nephrotoxic and further exacerbate the AKI. Type 3 CRS. This is also CRS in acute setting. CRS3 is identified by gradual reduction in kidney function as a result of AKI, ischemia, or glomerulonephritis, leading to acute cardiac impairment. AKI is associated with 58% increased risk of heart failure and a 40% higher risk of acute coronary syndrome and 15% increased risk of cerebrovascular disease. Coming to pathophysiology of cardiorenal syndrome type 3. And the underlying diseases are glomerular disease, interstitial disease, acute tubular necrosis, acute pyelonephritis, or acute urinary obstruction. All of this lead to decrease in the GFR, which causes retention of sodium and water. And due to AKI, there is increase in the renin-angiotensin system, aldosterone system activation, increase in SNS activation. This leads to further retention of sodium and water and increase in the vasoconstriction. Because of this increase in sodium and water retention, there will be volume expansion and increased preload, which causes hypertension and also precipitates heart failure. Because of the increased vasoconstriction, there will be increase in the afterload, which also precipitates heart failure. Apart from this, there will be increase in the humoral signaling, leading to increased oxidative stress and cytokine secretion, which can also exacerbate the heart failure. And AKI also causes electrolyte disturbances, acidemia, and coagulation abnormalities, which can result in arrhythmias and ischemic insult, leading to heart failure. Coming to type 2 CRS, this is a CRS in chronic setting, it is identified by persistent cardiac dysfunction that causes CKD over time. We know that both CKD and heart failure are chronic inflammatory diseases that cause production of pro-inflammatory molecules. So these biomarkers are important for tissue injury in both the systems, which result in fibrosis and cell death. CKD is common in heart failure with prevalence ranging from 20 to 57% in chronic heart failure patients. So what is the pathophysiology behind type 2 CRS? In patients with chronic heart failure, there will be altered sensitivity to vasodilator factors like ANP, BNP, and nitric oxide, which leads to chronic kidney disease. There will be increased renin-angiotensin system activation and SNS activation, which causes increase in vasoconstriction, reducing the GFR, thereby causing chronic kidney disease. And also, there will be increased in humoral signaling, leading to oxidative stress and cytokine secretion, which causes chronic kidney disease. Apart from this, the molecules like CRP that accelerate the atherosclerosis, microvascular and macrovascular changes, leading to CKD. And there is also, due to volume overload, there will be increased in intra-abdominal pressure, CVP, venous congestion, causing decrease in the renal pressure gradient, leading to CKD due to renal venous congestion. And there is decreased cardiac output, leading to decreased perfusion, leading to reduced renal blood flow and causing chronic kidney disease. And on top of this, there will be repeated insults to the kidney due to acute decompensation, diuretics, ACE inhibitors, drug-induced hypovolemia, and hypotension, further from increasing the progression of CKD. Coming to type 4 CRS, it is defined as on the basis of CKD as a cause of cardiac dysfunction. Renal dysfunction is an independent risk factor for cardiovascular disease. Ischemic coronary disease affects around 40% of ESRD patients, and chronic heart failure affects nearly 40% of them. So what is the pathophysiology behind cardiorenal syndrome type 4? CKD, it increases the renin-angiotensin system activation, increases the sympathetic nervous system activation, which leads to sodium water retention and vasoconstriction, which increases both the preload and afterload, thereby precipitating chronic heart failure. And it also increases the humoral signaling, and, which increases the cytokine secretion and oxidative stress, leading to chronic heart failure. Apart from this, in chronic kidney disease, there will be elevated FGF23 levels, which leads to calcium and phosphate abnormalities, which causes coronary and tissue calcification, causing chronic heart failure. And there will be erythropoietin resistance, causing anemia, which can also lead to chronic heart failure. And in CKD, there will be accumulation of protein-bound uremic toxins, which decrease the endothelial proliferation, impair the wound repair, and further cause chronic heart failure. CRS type 5, this occurs secondary to systemic diseases, which can cause simultaneous damage of both heart and kidney. Based on the pathophysiological process and severity of the disease, CRS5 can be divided into 4 stages. Hyperacute stage, which is 0 to 72 hours after diagnosis. Acute stage, which is 3 to 7 days after diagnosis. Subacute, 7 to 30 days after diagnosis. Chronic is 7 to beyond 30 days. Type 5 CRS, pathophysiology of type 5 CRS, systemic diseases like diabetes, amyloidosis, vasculitis, sepsis, sarcoidosis, and cirrhosis. All of this can lead to simultaneous dysfunction of both heart and kidney. First is the hemodynamics and inflammatory markers play a major role in organ damage in case of this type 5 CRS. Hemodynamic changes like hypoperfusion, increase in the systemic vascular resistance can cause organ dysfunction. The exogenous toxins, antibiotics, contrast media, whatever we are using for investigation purpose, that can also cause to organ damage and dysfunction. Endotoxin release and monocyte activation, oxidative stress and inflammation due to these systemic diseases can cause organ dysfunction and damage. And all these systemic diseases can also lead to sympathetic nervous system activation, renin-angiotensin aldosterone system activation, and neurohumoral stress, causing organ damage and dysfunction. Coming to the diagnosis, The traditional methods of diagnosis are GFR based. GFR remains the gold standard for assessing renal function. Serum creatinine, it reflects only the GFR and not tubular injury directly. But to characterize AKI, it will be better to identify a molecule which correlates with the tubular injury. And also, serum concentration of creatinine begins to rise many hours after stabilization of AKI. So, and it is influenced by a series of variables such as age, sex, ethnicity, and muscle mass. And small elevations in creatinine in near normal ranges can indicate large reductions in GFR, which may further cause the under recognition of new onset renal impairment. So, by this we can come to a conclusion that increase in the serum creatinine, serum concentration of creatinine occurs only hours after the stabilization of AKI. So we need a molecule which can detect AKI early. Apart from this, there are the other investigations are imaging of both heart and kidneys. A transthoracic echocardiogram is invaluable in evaluating for wall motion abnormalities and other measurements like LV ejection fraction and detecting if there is a pericardial effusion or not. Renal ultrasound, it helps us evaluating the kidney size and function. A smaller kidney disease and renal echogenicity are consistent with chronic kidney disease. So, coming to biomarkers, as we discussed, creatinine is creatinine takes a lot. The levels of creatinine increase hours after stabilization of AKI. We need some molecules like biomarkers to identify AKI early. So, what is the ideal biomarker? Ideal biomarker is the one which is rapidly measurable, readily measurable, which has high sensitivity and specificity, which is cost effective, and which has a prognostic value. So there are biomarkers of glomerular function, biomarkers of tubular function, and certain cardiac biomarkers as well. Biomarkers of glomerular function are creatinine, urea, cystatin C, urinary albumin, and creatinine clearance. Biomarkers of tubular function are kidney injury molecule 1, NGAL, which is lipocalin 2, liver fatty acid binding protein, and urinary electrolytes. Cardiac biomarkers are troponin T, troponin I, NT-proBNP, pro-ANP, and pro-ADM molecules. All of these are measured in blood. And there are certain other biomarkers like plasma renin activity, aldosterone, IL-1 beta, IL-10, and endothelin 1. Cystatin C, as we discussed, it is a biomarker of glomerular function. It is a protease inhibitor and has clinical and has increased levels have significance in the setting of AKI. Galactin 3, it is its function is for cell growth and differentiation. Increased levels of this galactin 3 in the setting of CHF have a prognostic value. NGAL, this is this molecule is freely filtered through glomerulus and is completely reabsorbed in the tubules. But in case of AKI, there are increased levels of NGAL in the urine. N-acetyl glucosamine, it is a lysosomal enzyme, and its levels are increased in the urine in the setting of AKI and congestive heart failure. Kidney injury molecule 1, its function is for tubular regeneration, and in the setting of AKI, there are increased levels of KIM1 as well. Free fatty acid binding proteins, their levels are also increased in AKI. TIMP2 and IGF-BP7. These are cell cycle arrest markers or markers of oxidative stress as well. In the setting of AKI, these levels are increased, and uremic toxins in the setting of kidney failure are also increased. There's a study published in Indian Journal of Nephrology in 2013. This has shown that serum cystatin C is a better marker of renal function in early stages of AKI. It is less affected by other variables like age, gender, muscle mass, and ethnicity. So, use of serum cystatin C based GFR may be more accurate and useful for early therapeutic intervention. This is a graph adapted from a study where they have compared levels of biomarkers in patients post CVP having AKI and not having AKI. we can see that in patients having AKI, there is elevation of NGAL, KIM1, and cystatin C way before the creatinine levels have elevated. So, by this, we can say that these biomarkers help in early detection of AKI and help us to intervene early. So, coming to management of CRS, the different therapeutic strategies in CRS are first is regulation of volume status with diuretics and ultrafiltration, and next is RAS inhibition, either with ACE inhibitors or ARBs, ARNIs, and mineralocorticoid receptor antagonists. Other therapeutic strategies are beta blockers, SGLT2 inhibitors, and devices for cardiac resynchronization therapy and mechanical circulatory support devices. Coming to decongestive therapy, it can be either with diuretics or ultrafiltration. First, we'll start with the diuretic therapy. It aims to eliminate the clinical evidence of fluid retention, such as elevated JVP and peripheral edema. And it is found that there is improvement in cardiac function. Improvement in cardiac function is associated with improved renal function in patients with type 1 and type 2 CRS. Ultrafiltration is done in patients with ADHF and diuretic resistance and impaired renal function. In diuretic therapy, first we start with loop diuretics, either as intermittent doses or as infusion. There is no significance of no superiority of one over the other. Whenever there is diuretic resistance, which is defined as attenuation of maximal diuretic effect that ultimately limits the sodium and chloride excretion, is called as diuretic resistance. So, in case of diuretic resistance, in case of diuretic resistance, we have to add a thiazide or mineralocorticoid receptor antagonist to promote diuresis by decreasing the enhanced sodium reabsorption in the distal tubule. So, what are the mechanisms of this diuretic resistance? It is either an inadequate diuretic dose, excessive sodium intake, or delayed intestinal absorption due to gut mucosal edema and decreased diuretic excretion into the urine, and increased sodium reabsorption from other parts of nephron not blocked by loop diuretics. So, to cover the last part, we are giving the thiazides and mineralocorticoid receptor antagonists, and also concomitant use of NSAIDs should be avoided because they can also contribute to diuretic resistance. These are the studies which compared diuretics versus ultrafiltration. All of these studies have shown that there is no much significance of one over the other, like diuretics over ultrafiltration, and effect on weight loss is also similar in both the groups in almost all the trials. CARES HF trial has shown that there is significant increase in serum creatinine with ultrafiltration, and CURE trial has shown that significant increase in serum creatinine with diuretic therapy at 6 months, and two trials have shown higher serious adverse events with ultrafiltration. This is a recent study, Edward study, published in NEGM in 2022. They have, in this study, they have added acetazolamide to the routine diuretic therapy, And the primary outcome that they have measured is successful decongestion, that is absence of signs of volume overload within 3 days of randomization and without indication for escalation of diuretics. Secondary outcomes measured are death from any cause or rehospitalization for heart failure during 3 months of follow-up and duration of index hospital admission. This trial concluded that addition of acetazolamide to the standard IV loop diuretic therapy in patients with ADHF was associated with higher incidence of successful decongestion. But there was no difference in death from any cause of rehospitalization for heart failure and duration of index hospital admission. This is sclerotic trial, which is published in 2023 in NEGM. In this trial, they have combined loop diuretics with thiazide diuretics for decompensated heart failure. And the primary outcome that they have assessed is changes in weight from baseline to 96 hours. addition of thiazide diuretics to loop diuretics has shown that there is significant decrease in the weight from baseline to 96 hours, but it is at the cost of impaired renal function, um, impaired renal function and hypokalemia in group receiving hydrochlorothiazide. Coming to further management, it is next is RAS inhibition with ACE inhibitors, ARBs, ARNIs, and mineralocorticoid receptor antagonists. What happens is from activation of RAS, there will be excessive salt and water retention, which alters the cardiac preload and afterload, and further worsens cardiac and renal function. So to break this cycle, we initiate RAS inhibitors with either a ACE inhibitor or angiotensin receptor blocker to prevent further cardiorenal injury. ACE inhibitors should be used with caution in patients with CRS, and renal function should be monitored closely during initiation and uptitration. Whenever we are uptitrating the ACE inhibitor, there should be a concomitant reduction in the diuretic dosage. And we should avoid simultaneous use of NSAIDs and ensure that the patient is not hypovolemic at the onset of treatment. Aldosterone, it plays a major role in cardiac, vascular, and renal remodeling by promoting oxidative stress, inflammation, fibrosis, and hypertrophy. So in order to inhibit this neurohumoral surge, we start mineralocorticoid receptor antagonists. But patients should be carefully monitored for hyperkalemia when started on mineralocorticoid receptor antagonists. Then beta blockers, these are shown to improve ejection fraction in heart failure patients and elevate the symptoms and prolong survival. But the benefit of beta blockers in chronic kidney disease is still uncertain. Then coming to the ARNIs, the ARNIs, they enhance the effect of natriuretic peptides, thereby promoting natriuresis and diuresis. These are useful predominantly in chronic heart failure with reduced and mid-range ejection fraction without cardiogenic shock to improve morbidity and mortality. So there is a trial published in NEGM in 2014 where they compared ARNI with enalapril in heart failure, and they found that ARNI was superior to enalapril in reducing the risks of death and hospitalization for heart failure. Coming to further treatment, there are certain novel therapeutic strategies like SGLT2 inhibitors in use in CRS. What do these SGLT2 inhibitors do? They basically decrease the blood glucose, they decrease the plasma volume. By decreasing the plasma volume, they increase the hematocrit and hemoglobin, which improves the cardiorenal outcome. And also there will be decrease in the systolic blood pressure and decrease in arterial stiffness, which further improves the cardiorenal outcome. And because of decrease in blood glucose, there will be altered cardiac substrate preference, which improves the cardiorenal outcome and promotes weight loss. And decrease in the this also decreases the adipocytes and decrease in the inflammation, which improves the cardiorenal outcome. So what are the benefits of SGLT2 inhibitor in heart failure and CRS? As we have seen that there will be decrease in plasma volume with SGLT2 inhibitors, there will be reduction of preload, and decrease in the systolic blood pressure and decrease in the arterial stiffness causes decrease in the afterload. There will be reduction of left ventricular remodeling, improvement in systolic and diastolic myocardial function. It has vasoprotective effects as well. Due to decrease in the plasma glucose, there will be reduction of HbA1c, and it also increases ketogenesis and helps in weight loss. There is a reduction of tubular cells and stress and increase of erythropoietin and hematocrit with SGLT2 inhibitors. And there is also reduction in albuminuria with SGLT2 inhibitors. So there are several studies conducted on SGLT2 inhibitors and kidney disease right from 2015 till 2022. So the studies which have shown efficacy of SGLT2 inhibitors in cardiovascular outcomes are when studies like Canvas program, Credence trial, declared TIMI 58, EMPA-REG outcome. All these studies have shown that when started in a preclinical disease, that is when the heart failure has not established, and in patients with type 2 diabetes, there is a reduction in heart failure related hospitalization when SGLT2 inhibitors are used. And studies like DAPA-HF deliver heart failure with preserved ejection fraction, Emperor preserved and Emperor reduced. All of these have shown that SGLT2 inhibitors are helpful in the treatment of established heart failure as well. And studies which have shown that positive renal outcomes with SGLT2 inhibitor are Canvas program declared TIMI 58 and EMPA-REG outcome. They have shown that when SGLT2 inhibitors are started in patients with type 2 diabetes without established CKD, there is slowing in the decline of renal function. And also in patients with CKD, usage of this SGLT2 inhibitors helps in slowing progression of established CKD. Other novel therapeutic strategies are VAPTENS. Actually, there is an elevated arginine vasopressin levels in heart failure due to activation of RAS pathway and have adverse effects resulting in deterioration in cardiac function, leading to peripheral vasoconstriction and increased afterload through V1A receptors. And through V2 receptor, there will be water retention and elevation in the preload. So these VAPTENs have been shown to have a favorable effect on heart failure. They are helpful in weight reduction, increasing urine output, and correcting the serum sodium levels without impacting the renal function and serum electrolytes by its action on neurohumoral pathway in cardiorenal syndrome. So this trial, Everest outcome, was published in 2007. It is a multi-center double-blind randomized control trial. In this trial, they have initiated tolvaptan in one group versus placebo in other group. And the primary outcome measured was all-cause mortality, cardiovascular death or hospitalization for heart failure. Secondary outcome was percentage of cardiovascular mortality. They have concluded that tolvaptan initiated for acute treatment of patients hospitalized with heart failure had no effect on long-term mortality or heart failure-related morbidity. But it was helpful in relieving the congestion without any harm on kidney function in patients with volume overload and cardiorenal compromise. It can be beneficial in elevating congestion and preventing or reducing renal dysfunction by maintaining renal perfusion and avoiding intravascular volume depletion. Other strategies are cardiac resynchronization therapy, which has been used for treatment of heart failure. This has improved renal function by improving the cardiac output, increasing the mean arterial pressure, and decreasing the central venous pressure. It also reduces sympathetic nervous system activity by decreasing the adrenergic tone, which ultimately contributes to improvement in renal function. Then there are mechanical circulatory support devices in case of renal dysfunction due to decrease in the cardiac index. These LVADs can also be used as a destination therapy as an alternative to heart transplant. The pre-LVAD implant renal dysfunction predicts the mortality after LVAD implantation. So, timely referral for LVAD therapy before heart failure worsens and leads to CKD is important. Renal function usually improves after LVAD implantation for 1 month, and after 1 month, there is no further improvement in the renal function. Coming to treatment of individual types of CRS, in CRS type 1, we initiate with a decongestive therapy in acute heart failure and watch for any renal failure during the treatment. If there is any worsening in the renal failure, first we have to exclude the post-renal factors and check for a diuretic response after excluding. What is a good diuretic response? It is urinary sodium concentration more than 50 to 70 milliequivalents per liter 2 hours after diuretic, and urinary output more than 100 to 150 ml per hour during the first 6 hours after diuretic, and a total diuresis of 3 to 4 liters in the first 24 hours. So if there's a good diuretic response and worsening of renal failure, we consider it as a pseudo worsening of renal failure and continue decongestive therapy until DREP. And if there's a poor diuretic response, then we can relook for congestion, assess the CVP, consider transthoracic echocardiography, consider measuring intra-abdominal pressure. If there is an increase in intra-abdominal pressure, we can consider paracensis. If the congestion is absent, it is considered as pseudo worsening of renal failure. And if there is congestion, we have to check if there is any associated hypoperfusion and hypotension as well. If there is associated hypoperfusion and hypotension, we have to discontinue or reduce lowering BP lowering agents and consider use of inotropes and vasopressors if there is decrease in the cardiac output. If there is no hypoperfusion and hypotension, we can increase the diuretic intensity and consider IV vasodilators. If with increase in diuretic intensity, there is improvement, then the worsening of the renal failure is due to congestion. So we have to further achieve decongestion and reduce diuretic dose when dry. If there is no improvement with the increase in the diuretics, then it is a therapy resistant worsening renal failure. So in these patients, we have to consider hemodynamic guided therapy, that is mechanical circulatory devices, and consider ultrafiltration if there is volume overload. And if there is no improvement with inotropes and vasopressors, again we have to consider the mechanical circulatory support devices. On top of this, we have to adjust the doses of medications which are cleared through kidney, and we have to avoid nephrotoxic drugs like NSAIDs, aminoglycosides, and contrast media. Coming to treatment of CRS3, we have to see whether this acute kidney injury is associated with oliguria or not. If it is associated with oliguria, we have to measure the urinary and serum sodium, serum urea, and serum creatinine. If urinary sodium is less than 30 millicoulomb per liter and serum urea serum creatinine ratio is more than 20:1, then it is considered as pre-renal AKI. Cause can be either volume depletion and acute heart failure, which has to be dealt as per the cause. Then if there is no oliguria, we have to identify the cause of the AKI. For this, we have to perform a renal ultrasound. If there are bilaterally small kidneys, it is considered as CKD and should be managed in the same lines. If there are normal size kidneys, then we have to send a urine analysis and renal biopsy. Based on the findings, we have to treat the disease. Then if there is a hydronephrosis, it is post-renal AKI, and we have to remove the obstruction. In case of a non-oliguric AKI with fluid overload, a loop diuretic should be considered. And in case of AKI, electrolytes and electrolyte disturbances and acidemia should be addressed in order to prevent arrhythmia and ischemic arrhythmias. And RRT should be considered if they are unresponsive to diuretics, and if there is severe metabolic acidosis and hyperkalemia and signs and symptoms of uremia. Coming to treatment of CRS2, this is chronic heart failure with worsening renal function during follow-up. If there is, we have to see if this worsening renal failure is correlating with uptitration of RAS inhibitor. If yes, we have to see if the serum creatinine is increase is less than 50% and less than 3 mg per deciliter, and GFR is still more than 25 ml per minute. If yes, then we have to consider it as pseudo worsening of renal function. If not, we have to see if there is any hyperkalemia and serum creatinine increased by 100%. Then we have to discontinue if this turns out to be positive, we have to discontinue the RAS blockers and consider other forms of afterload reduction. With this, if there is improvement, it is pseudo worsening of renal function. If no improvement, we have to consider it as a true worsening of renal dysfunction, worsening of renal function, and stop other nephrotoxic drugs and consider renal artery stenosis and other causes for worsening of renal function. Now, if the worsening of renal function during follow-up is not correlating with uptitration of RAS inhibitor, then we have to look for congestion. If there is congestion, we have to treat congestion. If there is no congestion, we have to check for hypoperfusion and hypotension. If it is present, we have to reduce the doses of diuretics and RAS inhibitors or other antihypertensive agents. If there is improvement with this strategy, it is a true worsening of renal function. And if there is no improvement, it is therapy-resistant worsening of renal function. In this case, we have to consider either a maintenance dialysis if there is a volume overload, and if it is due to hypoperfusion, then we have to consider mechanical circulatory support devices and transplant. Coming to treatment of CRS4, we have to address a chronic kidney disease here. To decrease albuminuria, we have to start on RAS blockers, either ACE inhibitors or ARB, avoid further nephrotoxic drugs, and to address hypertension, we can start on RAS blockers, beta blockers, and mineralocorticoid receptor antagonists. For the calcium phosphate abnormalities, we can start on phosphate binders and calcium citrate. Treat any reversible causes of CKD, and chronic acidosis and hyperkalemia should also be addressed. Fluid overload can be decreased with diuretics and maintenance hemodialysis. And to address anemia, we have to start on erythropoietin and ferrous sulfate injections. And dyslipidemia can be addressed with statins. Coming to treatment of CRS5, it is due to systemic illness. So the primary illness has to be addressed first. We have to treat the underlying conditions. Pharmacological management of CRS5 is with RAS blockers, beta blockers, diuretics, inotropes, and vasodilators. And non-pharmacological management is with dialysis or transplantation. So to summarize, we have to distinguish true AKI from functional causes of fluctuation in serum creatinine. That is in the context of diuresis for acute decompensated heart failure. That is, we have to differentiate worsening renal function from pseudo worsening of renal function. And we have to identify the factors that are contributing to diuretic resistance for optimizing the decongestion in CRS. Biomarkers of cardiac and kidney injury represent a new dimension in the diagnostic algorithm in evaluating heart failure with impaired kidney function. And they also offer a prognostic value in acute and chronic CRS. High quality data for goal-directed medical therapy in chronic CRS with moderate to severe decline in kidney function are lacking. They represent the areas of research in future studies. A multidisciplinary approach is required for cardiac device therapies to reduce arrhythmia burden in patients with heart failure and CKD. Palliative care should also be used in order to improve the quality of life. And a multidisciplinary approach is essential in joint management of patients with CRS. Thank you.
Thank you, Josna. I think it was an excellent and comprehensive summary of a complex series of syndromes. And this we see quite often in the intensive care units, not only the patients with CKD and cardiogenic shock who come with different variations of acute kidney injury, but we also see patients who do not have either of these two problems coming and both important. So it is a very practice, and I think you reviewed it. Forms of activity it is also important that acute kidney is not a single system disease, it's a multi-system disease. There is significant organ crosstalk in to the kidneys quite often is the lung. Previously, we were taught that what is good for the kidney is not good for the heart in terms of fluids, and what is good for the heart is not good for the kidney in terms of diuretics. But that paradigm, especially realize that volume overload is equally bad for the kidney. But most importantly, what is good for the kidney may not be actually good for the heart or for the lungs, and what is good for the lungs may not be actually good for the heart and kidney in terms of your ventilatory strategies and your PEEP. So cardiorenal syndrome, I think, has now got to be seen in the context of heart-lung interactions and organ crosstalk also. With the availability of biomarkers, especially the nephrocheck, including the BNP, BNP is something that is intrinsically related to the heart, the kidney, and probably even the lung at this point of time. So a thorough understanding of these mechanisms and the relevance of these patterns is very important for the management of these patients. Previously, volume overload was considered as a very strong prevention of volume overload was considered a very strong indication for the initiation of CRRT for the protection of the kidney and therefore protection of the heart. Whether that paradigm is still valid, we are not sure because the indications, early initiation of CRRT for volume-based indications doesn't seem to be improving the outcomes of these patients or reducing the incidence of acute kidney injury. As Jyotsna has said, we need to look at biomarkers in a very pragmatic way. What we are looking at this point of time in terms of renal function are functional biomarkers like creatinine, EGFR, or any other of these tests we are using. But what is essentially important, as she has shown in the graph and as we have already presented before in the World Congress in Seoul, is that structural biomarkers of acute kidney injury are very crucial and they antedate the functional biomarkers as early as 48 hours. So if we can find an ideal structural biomarker for kidney injury and combine it by evaluation of a biomarker of myocardial injury, we may be able to prevent some of these instances of type 5 cardiorenal syndrome. The availability of SGLT2 inhibitors and ARNIs has probably changed the way the chronic forms of renocardiac and cardiorenal syndromes are managed, but their established role in the management of an acute form of these two syndromes still needs to be evaluated in a major randomized control. So that's all I have to say. Thank you all for joining us today. Next week, actually, we will be traveling. Me and Ghanshyam will be traveling to Kolkata for the annual Congress on the Tuesday. The workshops start on Wednesday. So since both of us are involved in a couple of workshops, we won't be available on Tuesday. So we will postpone next week's lecture. We will resume on the 5th of March. Those of you who are traveling to Kolkata for the annual Criticare can talk to the teams. We will be there. You can meet us and you can advise us on how to make this morning program more interesting and more appealing and serving the needs of the students for whom this program is targeted. Have a good day and meet you all again a week after the next on the 5th of March. Bye bye.
Thanks.